So, implant planning of patient name Bindu. She's a 39-year-old female patient hailing from Ottapal of Haritha. She's a bank employee by profession. Patient is already under implant therapy. We have placed implant on two
So how many implants do you have? One is already being placed. Is it a full mouth rehabilitation or only one corner?
full mouth rehabilitation.
Upper and lower. And see the clinical and the radiography. Okay, what is that? What is that you showing the generally line? Yeah. What is this?
This is the present part that we've already placed one implant, which is of 3.3 into 13 mm. Now we are planning for individual either of 1 3 or 1 2 or 1 2 or 3 digit in between 1 4 and 1 5 and 1 6.
She has got how many teeth left now? Teeth and few roots also. What is the periodontal condition of all those teeth?
They are all periodontal compromise.
Like are they mobile or somewhat tedious those teeth decay?
This is completely given the roots themselves.
Okay, the other teeth they are all mobile.
They are all mobile. Only 8 is not mobile.
8 is stable. Rest are all mobile. What was the reason for this? Is this person undergone any kind of treatment that has resulted in it or neglected mouth? What was the condition? Why are those teeth mobile? Can you see the clinical picture? Patient must be having some habits related to this. What are they?
Tongue thrusting is this.
Tongue thrusting is already there. Severe tongue thrusting. Age?
She's 49.
49. 49. This person, it's a lady. Has she undergone any orthodontic treatment?
So 21 years back, she's already undergone flap surgery, full mouth flap surgery, she's undergone.
Flap surgery has been done 21 years ago. That means from that time she's suffering from the orthodontic problem. So that means you have to expect a good amount of bone loss around the existing teeth and much bone loss in already dangerous areas. Altogether, it must be a very compromised condition. And the second arch from this side doesn't have molars also. It looks like a very compromised condition even for an implant placement. Okay, so you're planning a full mouth rehabilitation. Upper and lowers are to be extracted. And what kind of a processes are you looking forward with? Like a patient will come to you and you will promise patient regarding some kind of a rehabilitation. But you have to give some idea to the patient how those teeth are going to be, right? Because all your implants has to be focused into one point. That patient should be happy with whatever is to be, whatever treatment that person gets. So that patient will have certain amount of dreams. The patient has got some expectation. And finally, the patient's expectation should meet with the planning which you have done today. Whatever you plan today is what the patient's expectation about the final processes, what that person is going to get. So if your planning is something else and the patient's expectation is something else, then the patient will never be happy. So unless you have a real idea on what kind of a process you are going to finally deliver to the patient, you won't be able to convince the patient, or rather you won't be able to regulate the dreams what that person has about the final look on them. So what have you told the patient? How will you rehabilitate her until? What have you told the patient? This is going to be a final kind of teeth what we are going to deliver you. Is it a kind of fixed prosthesis? It's fixed prosthesis. It's not an overdenture prosthesis. Not reliable to one or two implants. Then you give a denture which has to be removed by the patient, cleaned and kept back. Not that one. You have promised patient on a fixed prosthesis. Right? So what kind of a fixed prosthesis it is?
Implant supported FPD.
Implant supported FPD. You have got various other choices as well. Hmm? You could have a hybrid or an implant supported prosthesis. Again, you can have a screw retained or a cemented one. If it is screw retained, then you can call the patient once in a while, remove it, clean it, and give it back. If it is cemented, then that part is not at all possible. So you should have a fair good idea on what kind of a processes you are going to deliver finally. Because remember always, patient didn't come for implant. Patient came for you. It was your suggestion that patients are undergoing this kind of surgical procedures to have a fixed teeth there. So it's your responsibility that finally whatever you deliver has to be a fixed process. If not a fixed process, then you should be able to tell the patient before itself, prior to it itself, that your bone are very less, we don't have enough rich. So we'll have to restrict to one or two implants on top and down, which will finally become an overdenture, which you'll have to remove and keep, but it will be firm inside the mouth. Not like the normal removable complete denture. It is sort of a removable one, but it can be fixed to a ball and socket abutment, or it can be semi-fixed to the ridges. Whatever it is, the way you can explain so that the patient will understand it very well that that person is not going to get a fixed 5 So, keeping it apart, you have done a planning to give a fixed prosthesis. A fixed process, an FPD, implant supported FPD. So you're starting with the upper or the lowers? Uppers. So you're assessed it to have all having more than grade 2 mobility or?
Grade 2. Only one piece was grade 2.
That is 8.
One 2 has grade 2.
So one of those teeth on top has got grade 2 mobility. Grade 1.
Grade 3.
Grade 3. Rest are all?
Grade 2.
Grade 2. So definitely it is for the extractions alone. So all the teeth are to be extracted. Which are having grade 1 or 2 or grade 3 mobility. So your treatment plan should be varying accordingly. A firm tooth extracted because of a fracture or a caries, where you're going to place an implant, immediate implant is totally different scenario from a tooth having mobility. A tooth which is mobile will have what are the prime things that will come into as a hindrance for you in placing a implant in the right position. The prime hindrance for you. A mobile tooth has to be extracted and you place an implant there. What will be the prime hindrance that we take in mind? Now, what is that? That's going to uh, uh, block your planning by any chance.
Available bone. Available bone.
No, a tooth is mobile. All your planning will be based upon an X-ray or a clinical picture. Knowing that this much of bone is present there, this much of bone is there apically to the tip of the root, all those planning will be done. But what is going to be a hindrance for you when you really go when you try to place it in the patient's mouth? A mobile tooth will have an inflamed bone around it. Stability, you mean the final stability of an implant. That is much later story. Initially, once you extract it, and when you try to do an osteotomy in that side, what is that going to give you a real challenge? In the primary point itself. First thing what you're going to do is to place a good lens drill in place for two things. To fix the position and angulation. Will you encounter any problem in that particular point? In a conventional osteotomy site, where you have sufficient width, sufficient span of sufficient long span, everything possible, you can decide on which area you're going to place the lance drill and poke it. It's fine. It can be done easily. But in this condition, you do not know which will be the angulation if you follow the pattern of root. Will you land up in the same angulation position if you follow the tip of the existing tooth root? You're not sure about it. Because you might need to place an implant at a different angulation from the present condition of the tooth. Reason it is mobile, so it is shifted. A mobile tooth would have shifted from the normal position. So if you follow the least resistant path, or if you follow the position of the root, you might land up in placing implant at a different angulation, which is not desirable for you. This is not desirable for the parallelism, which might land up in a condition where you will be forced to place a cemented restoration instead of restoration. So your planning should bear in mind, you should have certain other plans where you might have to shift the initial lance position in between, because you're not going in for a guided implant placement here. It's not a guided drilling protocol. So everything is dependent upon the way you're going to hold the lance drill and probably the pipe drill. So the biggest challenge that you're going to face in placing an immediate implant is deriving the right position. Once you get that position right, then everything is easy because the mobile tooth will be soft, having soft bone. Drilling protocol will be easier than a conventional one, considering the resistance in that local area. But any moment you can again go wrong because you don't have a primary stability for your drill as such in an immediate implant placement. You won't get a proper guidance of the drilling. When you insert a lance drill or a pilot drill, the reason behind this, you don't have a stable bone around it. You have a hollow space instead of a stable bone. So you will be drilling from the apex of the tooth, which is already extracted off. And throughout that area, over that around the drill, you don't have any resistance on the bone side. So placing it exactly in that position which you need tremendous skill and probably a kind of a skill that will be beyond the least resistance path finding way. You have to go and place the implant exactly in a position which probably may not be the guidance from the density of the bone. Density of the bone might be less at a different place, where your drill tend to move to that area or displace to that area, which won't be the area where you would like to place your implant. So your stability of that initial lance drill, the place where you have kept the initial lance drill, and the momentum at which you drill, and the control over the handpiece and the drill matters a lot. Even if it takes to a least resistant area, you should be firm enough to hold and drive it to the right position of the implant. So don't just leave the drilling sequence to the resistance of the bone or any kind of misguidance in that area. Once you hold the handpiece firm, that direction should be the same throughout your drilling protocol. You understood? So everything matters. The positioning of the patient's mouth, the patient's face, the place where you sit. And it's very important for a beginner not to turn their head away from the area where you have taken the initial drill. Because the next drill can again change the direction. So as I always tell you, once you're seated in one position, don't change your position. Even if it is possible, don't change your vision also. So once you've done the lance drill, give back the handpiece to the assistant. Let that assistant change it into your pilot drill and give it back to you. You fix your eyes in the same position so that the next drill will go into the same position. Otherwise, if you change the patient's mouth or the angulation, let the patient speak, or you change your position to adjust and replace the drill. Then when you come back, you will get a different view of that region. Then you go in a wrong direction again. Because your tip of the root may not be the right position for your implant to be implant planned. So you can change, you can get misguided in between. So always be careful that you don't change your vision to that area, and always have a feel of that feel of that drill which you have placed initially. Throughout your drilling sequence, you should have the same angulation in the patient's mouth in terms of viewing it and in terms of drilling that area. It should be a fixed vision. You follow that. So taking into consideration, now we have placed one implant. Which area have we done the implant placement?
2, 3, sir.
Can we see the present X-ray condition? So one implant is being placed in which region is that? 2, 3.
2,
So 2, 3 was extracted and you already placed an implant. So it was an immediate implant.
3.
Now how many do you plan in the upper arch? 2 itself. So it's closer to the other implant. So how many millimeters apart the next implant can be planned? 3 millimeter from the outer diameter of the present implant to the outer diameter of the implant plant. So that means the implant's outer diameter, the outer surface of the implant should be 3 millimeter away from the nearby implant. So the right position of that implant has to be much away from the present implant. So the lance drill which you are planning, the initial drill, should be positioned at which point? How many millimeters away from the present implant? Minimum 3 millimeter plus
1.5.
plus the radius of the upcoming implant. So roughly about
1.5.
So roughly about 5. So the present implant should be planned that your initial drill, the initial drill for osteotomy should start from 5 millimeter, 0.5 millimeter minimum away from the present implant. What is the distance that you will get if you add the interdental bone and the width of the present drill, the present lateral? How much is the width of the lateral? Yeah, exactly. How much is that?
So with this 4.
This is labiolingual, labiopalatal dimension. How much is that?
4 at the cross. 4 and
4 millimeters. This is a lateral incisor, right? So it is flattened. It's a flat root. What is expected is a flat root. So this is 4 millimeters. It will be lesser than that or more than that. Considering it as a hollow one, as circular in its anatomy, it will be 4 millimeters.
could be more.
Yeah, the width of the lateral incisor root will be 4 millimeters. Consider it as 4. So 3 millimeters has to be left from the nearby implant. So that adds up to 5 millimeters. 2 millimeter radius and 3 millimeters space between the two implants. Am I right? So 5 millimeters is almost a right tip. Should I repeat it? 2 millimeter radius of the diameter and 3 millimeters to be left between the two implants. So it makes 5 millimeters. So 5 is the permitted one. If you are going to place it in the lateral incisor radius, 5 millimeter away from it. So interdental bone width has to be assessed. Plus whatever is there available, it should be 5 millimeters away from the nearby implant, which is already inside the bone right now. So we need to open up that area and see where the present implant is. And then from there, 5 millimeters away, we'll have to place it. Or should have a fair good idea on how much is the interdental bone or interimplant bone. From there, how much millimeter away can we plant the present implant. Otherwise, if you follow the lateral incisor per se, you might land up in a condition where two implants will be too close and both will be of no use when you place the final processes. If it comes too closer, as such, we are going to place 4 or 5 or 6 implants on top. 2 implants closer means it's not going to serve a purpose of stability. And 2 implants too close means the inter-implant bone is definitely going to undergo resorption or peri-implantitis in future. More than that, to plan a prosthesis, you should have a minimum of 3 millimeters of gap between 2 implants. Between a tooth and an implant, you can have some kind of a compromise. But between two implants, 3 millimeters definitely required. Understood? So it should be 5 millimeters away from the nearby implant at present. So that has to be assessed and did accordingly. Now considering the position, which area will you choose in this condition? So 5 millimeter away from the nearby implant is fixed. And which will be the position of this implant in terms of the labial-lingual bone availability? Do you want to place it more lingually? Do you want to place it more buccally? Or do you want to place it in the center? Let's have a look at the clinical picture. It's proclaimed labeling. Naturally, it had a tongue-twisting habit prior to this, or a reason of this proclamation tongue-twisting habit. So naturally, that you have a proclaimed tooth as such. So if you plan a tooth exactly in the position of the lateral incisor, the final process is going to be cemented. Because your hole is going to come on the labial side. Or you have to plan something accordingly, but still the hole is going to be on the labial side. So would you suggest something else? Rather than following the pattern of the root? How much ever possible, go palatally. So will the palatal bone allow it? See the series now. Yeah. This is 2 region. So will the palatal bone allow it? How much of palatal bone is left behind? You hardly see any bone there, right? All you get is bone beyond the apex. Right? You have 3 sections here. Which are these 3 sections? From where have we taken these 3 sections? the slide prior to this, please here. You see there that section through the middle of lateral incisor. So that means you have got three sections there. One will be distal to it, one will be mesial to it, and the middle one will be at the center of the lateral incisor. Okay, let's have a look. In that we have a close observation. The left side one. The left side one compared to the right side one, not the center one. They both have good amount of bone or good availability of bone from the crustal area till the base.
Yes.
And the central portion has got still better. So that means the mesial area has got 12 millimeters of bone from the crust. The height, we are talking about the height. 12 millimeters of bone from the crust till the nasal floor. The central portion has got that red line I am talking about. The central portion has got 13.5 millimeters from the existing bone crust to the nasal floor. In that 6.1 millimeter is existing root itself. 6.1 millimeters existing root, and beyond that is your another 6.1 millimeters you will get within the bone. Alright? So you can plan something which will get a primary stability beyond the effects of the root up to 6 millimeters. This is very welcoming tip. And you have got same amount of bone on the mesial and the distal side as well. That is very important. That's very important. So if you plan something from within this 3 millimeter area, you can plan something which is slightly angulated towards the palatal bone. You will get good support from the nasal side. Imagine if you had a bone which was in much favoring your labial side placement, or which is not favoring your palatal side placement, then you don't have any other option other than going for the same position. Now you've got an option of fixing the implant to the lingual bone as such. And naturally, then we have to think about grafting the buccal side. Reason we'll have more jumping space on the labial side. Since you have placed this implant onto the palatal side, more jumping space is expected on the labial side. So we need to plan some kind of a grafting procedure with whatever accessories we need to place it in the labial side. So that has to be taken care of. So when you plan an implant like this, we have to have an idea regarding the augmentation of this site. Because the bone graft is going to cost as much as an implant is. So if you have not planned it well, then finally you will end up in a condition where you cannot have an excuse of not having told the patient the treatment cost is going to be this high. Do you know how much costly are those bone grafts? So a bone graft is required here, parallelly to be placed. 6 millimeters of apical area you can have it. Then are you going to place it within the bone or subcrustally? Are you going to flush the implant surface to the bone crust or subcrustally? Minimum 1 millimeter subcrustally you can place it because some amount of resorption is expected here. So out of this 13.5, you will get only 12.5. And your implants, you have got size of 13 and 11.5. So you got the restricted 11.5 in this case. If there was an implant available at 12 millimeter, you could have tried it here. But you have got implant of the size of 11.5 mm. The kind of implant which you do it, your plan for this patient has got the size of only 11.5 or 13 beyond that. So you don't have a size of 12. So you have to restrict to 11.5. So 11.5, I am going to go place it completely into the bone till the nasal floor 11.5. Then you'll have 2 millimeters short of the crust. But you plan only for a millimeter short. Right? So how much are you going to prepare out of this entire length? If you take a palatal bone as the reference, what will be your preparation depth?
Prepare for 13 in place 11. Prepare for 13.5 in place 11.
The full length. You're planning for a full length. Not much of a risk involved here. So safer would be to go in for a full length preparation. But when you place the implant, place it within 11.5, that will be 1 millimeter suppressively from the crest of the palatal bone. This is a very safe way to do it. You're playing a very safe game because there may be a chance that you'll have to push it further another 1.5 millimeters from the palatal side, because as you go prepare the further bigger drills, you might land up in a condition where you use the crustal bone. So if you prepare 13.5, there are chances that finally you will have only 12 millimeter by the time you place the final drill. So considering that, in between some kind of a challenge, in between some kind of a condition where you lose some amount of crustal bone, still you will be able to place 11.5 if you have gone for a complete 13.5 preparation. So go for 13.5 preparation, but you don't have a drill with a perfect marking of 13.5, but you have it with 13. So it will be 0.5 millimeter pressed into the socket area. So that's how you're going to do the drilling. Slightly palatal, you place the lance drill, confirm it, removing the handpiece and place back the lance drill and confirm it. You have done it on the palatal bone very well. You need to have an extender with the lance drill to have this drill properly. Because otherwise, your lance drill alone will travel up to 6 millimeter or beyond it. You won't have much of drilling, a kind of a drilling plane beyond it. So we need to have some amount of visibility over the lance drill, which can be obtained by placing an extender on the lance drill, over the lance drill. So place an extender, lance drill, position it well, remove the handpiece, place back the lance drill and confirm the position, then pilot drill up to 13 plus. Because beyond the 13 on your drills, you have got the marking of 15. So it should be somewhere in between these two, but only 0.5 millimeter beyond the 13 marking. You will definitely hit the nasal floor. So you have to be careful with the lance drill and the pilot drill. Thereafter, the nasal bone won't give you much of a problem. Nasal floor. So you have to be very careful with the lance drill because that can penetrate the nasal floor. Even pilot drill can penetrate the nasal floor. Beyond it, your drills become larger, which won't be very easy to penetrate it. So you have to be very careful with your lance and your pilot drill. Once the pilot drill has obtained the length, then it is just following the length, right? So what will be the diameter for this piece? 4 is the permitted bone width. So within that, how much diameter, what diameter implant can you place?
3.3 and 2.7.
You need to have how much millimeter of bone left on the labial and the lingual side? On the labial side, you need to have 1.5 millimeters of bone left. And on the lingual side, you need to have 1 millimeter left. How much is expected bone on the crustal area? How much is the bone width on the crustal area? You got only 4 millimeter?
Yes, sir.
Only 4 millimeter. That means the implant that you can place here within 4 millimeters, how much? You have to subtract 2.5 from it. So it's going to be an implant which is 1.5 millimeter diameter alone, which is not at all a normal implant at all. You won't get such a diameter implant here. So what is the next choice? You have to expand that area. Expand that area, or you should think of augmenting that area and placing the implant later. But here you can go in for an expansion of the site, width of the present bone condition. That will be to how much level? Your minimum diameter implant is how much? What is the minimum diameter of your implant? 3.3. 3.3 means you have to expand it to at least 5.7. One millimeter on both sides. You have to expand it to minimum 5.7. Right? So when you're planning to expand it, you should have 1 millimeter on both the sides present there, then expand it. So out of 4 millimeters, 1 millimeter should be there on the parietal side, 1 millimeter should be there on the lateral side, then you have to expand it. So the maximum diameter of drill possible here is 2 or 2.8. You can prepare 2 or 2.8, still you will have some amount of bone left behind. At least on the crustal side, we see 5.2 and 5.6 millimeter of bone. Sorry, the apical side, the base. So that means if you expand it to 2.8, which you have a drill, 2 or 2.8, thereafter you shouldn't be drilling that area. If you try to drill that area, you'll be wasting the bone inside the osteotomy area. After 2 millimeter or 2.8 millimeter of drill, we can go in for expansion alone. Are you going to directly place an implant and expand it? Or are you going to do some kind of an osteotomy expanders? We're going to plant an expander in this region and then place it. It's an immediate implant. Let's see for the density. What's the density of bone? D2. D2 bone. So that means it's not a very hard bone, but it's not a soft bone as well. So it's D2. D2 means it's a very ideal bone for a conventional one. So here if you try to expand it, will you lose your primary stability? If you use an expander, you won't lose the primary stability. But if you use a drill in this condition, you might lose the primary stability because you've got only 6 millimeters of apical area which is going to provide you the primary stability. So in that condition, if you see 2.8 drill, thereafter beyond 2.8, you have got only 0.5 millimeters difference between your diameter of the implant and the drill side. So your plan is expanded here. So is it necessary that you have to expand that area? You've got a split master here, bone expander here. We start from 2.6. The next size is 3. You have already drilled till 2.8. So you don't need an expander of 2.6 here. You'll have to go in for 3. Don't you think that's going to affect your primary stability if you expand it till 3? Because your implant is just 3.3. Out of this 11.5 millimeter of your implant, you will get stability only 5 or 6 millimeters. Is it necessary that you have to prepare it till 3? Or if you expand it till 3, and if you try to place the implant, if you don't get enough primary stability, that's a question. But only advantages, you have not drilled and removed the bone. The bone is still packed to its surroundings. So that when you place the implant, you will still get that primary stability. So you got two choices here. Let's feel the bone. And if you feel that bone is quite soft,
then avoid this 3 millimeter of osteotomy and go in for an implant placement directly after 2.8 drill. Or if you find that area to have a very firm bone, then you've got a choice of an expander of 3 millimeter diameter. The entire length has to be expanded. Then you can place 3.3. So your final implant in this position is going to be 3.3 into 11.4. Okay, fine. Okay, come to the next site. Next site, plan to place implant. Which is the site? 1, 3. So you place 1 in 2, 3, 1 in 2, 2, and then you're going to 1, 3, because that's the only area available, I think, I believe, in between. Okay, 1, 3. How is 1, 3? You have got how many blue lines there? 3. 3, okay. Which are those 3 separations? I think 4 or 3 only. Okay, fine. So you've got 3 lines here corresponding to the 3 sections which you're going to get in the next slide. Show that. These are the 3 sections. So in that you've got, see, very favorable condition in the center portion is. Can you see something very interesting there? Labial, compare the labial and the lingual bone. A very good, very firm, good, abundant palatal bone. Because you want to place it on the palatal side. So you can go closer to the palatal side when you try the drilling. Always put pressure to the palatal bone, not at all to the labial side. And another interesting thing is you don't need to angulate it too much because you have got sufficient bone there. Okay, so again the condition is same. What is the total length permitted here? Is it sinus floor on top or is it your nasal floor? Read the pink line. Distance from crest to the maxillary sinus. So here, that part you have to take care of. Compared to nasal floor, sinus floor is dangerous. So here you can go and hit the floor. There is nothing wrong in it. But going any millimeter beyond it, it is inviting trouble. Again, we are not doing a guided implant surgery. If it was guided implant placement, then everything would have been taken care by the guide itself. Here, when you plan it, you'll have to plan it probably to safeguard the base of the sides. So how much is the total permitted length of the implant that can be placed here? It is, how much is that? 15. The center is a red line. 15.9. Is it not? So out of 15.9, you can place an implant of 1 millimeter less than that. That is 14.9. What is the size of the implants that you have? 13 you do have. Then you have 15 only. So it has to, you'll have to restrict it to 13 here. The full length, if you get it, is 13. 1 millimeter shorter than that means 1 millimeter shorter than the crest of the alveolar bone. Again, you can apply the same principle which are used in the 2 region. Prepare it to the maximum. So what will be the maximum? Up till 15.9 you are safe. Going for 15. Let that 1 millimeter of space of play, let it be remaining there. So 15 millimeter of preparation with 13 implant. Position, maximum palatally, slightly angulated labial. Can't be straight anyway. Slight angulated labial. To follow the pattern of bone. If you place a very straight placement on the lingual bone, then naturally your drill tip is going to come out through the buccal side. So slight angulation, very slight angulation, 15 degree angulation onto the palatal bone. That would serve this purpose. Again, bone grafting is indicated because you will get much of a jumping space. Plus, whatever augmentation you can get out of that area, let it be there. Because it's not 1 millimeter that is desirable. You need 1.5 millimeters. So bone grafting in that area is inevitable. You have to plan it and do. So in these two cases, both cases would require bone grafting. So that definitely that involves a lot of money also. Okay. Yeah. What is the next site? Yeah, size what it is. You've got 6.6 in the crustal region. You've got 7 in the basal region in terms of width. So it's almost the same. So that means minimum of 6.6, maximum of 7. So out of this, considering 1 millimeter on both sides, it comes to, if it is 6.6, subtract 2 millimeters, 1 on both sides. 4.5 is desirable. You can place up to 4.5. Is it necessary that you have to involve the entire bone? If you have enough of length here, why don't you compromise a little bit on the diameter? If you have got enough of diameter possible, then go in for diameter. If that's not possible, because there are chances that you'll get a thread exposure if you go in for a maximum size implant here. It's not necessary that the entire immediate implant size should be filled with your implant. So which one? 3.75. So you'll still have another 1.5 to 2 millimeters beyond it, or less than that. Should it be 3.3? Make sure that you have got both the size implant with you. It all depended upon the clinical picture after you drill that site. You shouldn't land up in a surprise wherein you happen to break any of this bone and you cannot place an implant of that diameter and you don't have the diameter with you. That's going to be a serious trouble. So do have 3.3 into 13 and 3.75 into 13, but preferably 3.75 into 13. If not possible, go for the other one. Next slide. Which is the site. Between 1.4 and 1.5, you've got some amount of interdental bone, which is favorable. But both the teeth are to be extracted. So the interdental bone drilling needs precision. It has to be very precisely drilled. Because any moment of change in direction will break the interdental bone. Okay, let's see the CBC. How much is the length of span, edentulous span? There in between these two teeth, just 2 millimeter in the crust. We have only 2 millimeter in the crustal region. That is in the crustal region labiolingually, between the two teeth. Only 2 millimeters. So you got length also 2 millimeters. Only 2 millimeters of interdental bone crust. And what about towards the base? Is it more wider towards the base, this space? Let's see the previous panoramic one. It's wider towards the base. So if you happen to reduce a little bit of crustal bone, you will get more wider site for implant placement. So how much will you reduce? Reduce 2 millimeter means you will get the length of the implant is going to reduce now. Presently, you have got 5.9 millimeters, 3.1 millimeter, and 4.8 millimeter at the crustal level. And the center portion has got only 3.1 millimeter. But that is a very favorable thing. 3.1 millimeter is good. From 3.1 millimeter, if you can place an implant, you will get a length of 14.7. If you reduce 2 millimeters from there, you'll get 7.1 millimeter. 2 millimeter, you'll get 6.3. Yes, 6.3 you'll get. 2 millimeters less than that, you'll get 6.3 millimeter at the crest, which is more favorable, definitely. But how much will be the length? That area has got how much of available bone length? Bone length, we don't know. Okay, so this has got 6.3, which is more favorable. If you go 2 millimeter reduction, if you do in the crest, you'll get 6.3. This is more favorable to place it. But then 2 millimeter of reduction in the length you'll have to do. So you'll get only 12. You don't have implant of 12. You'll have to place 11.5. So it has to be 11.5. And what about the diameter? 6.3. Out of that, how much is permitted? Mind you, it's interdental bone. You have got two hollow space on both sides, which are edentulous sides. Either you'll have to wait and do a socket preservation and wait and do it later, or place it straight away. You're planning to place it straight away. So both sides will expand a little bit because it's two hollow space on both sides. You're going to extract both the teeth from either sides. So you'll have some amount of expansion possibly here. So what do you do now? Preparation till 6.3 out of that. Drilling sequence till what? 6.3. Which diameter are you planning? 3.75. So the entire 3.75 you're planning. So how much drilling? Till you can go up to 3.5. You can go up to, even if you try and expand too much of an expansion here on the interdental bone, that's going to fracture, crack. So drilling is required here. The other area we said expansion is required. Here drilling is required. If you try to expand this area, it's going to fracture. If it fractures, what will happen? The two edentulous site and the interdental bone becomes one. So it will become a huge defect there. Even your socket preservation will not work thereafter. So you have to be very careful in drilling here. So drill maximum. Avoid any fracture of that interdental bone. Plus graft both the edentulous site. You like to graft the two extracted site next to it. Yes. So placement of an implant with least stress there or least pressure, that means maximum preparation. If you want to still go in for 3.5 plus a countersink, do it. So you've got a countersink drill of 3.75, right? Right? So you can try that as well. So there will be no pressure in that region. You can directly place it. So in that event, if you happen to lose a little bit of bone, be prepared with the next length implant as well. At present, you're planning for into 11.5. You should have 10 also with you. Because in that process of countersink drilling or in this process, if you happen to lose any amount of crestal bone, then go in for the next diameter one. That is 10. So you should be having 3.75 into 10 and 3.75 into 11.5 with you. Is that clear? Next one. 1.6 area is something very similar. You've got 1.5 which you're going to extract it now. You already extracted to place the other one. Anyway, extraction you're going to do it all together in the beginning itself. So you got an interdental bone here. It's actually not an interdental bone. It's a site of 1.6. Site of 1.6, which is at present having a root stem on 1.7 region. And then again a root stem which you have already removed in front. How much is the span here? Available edentulous span. Between the root stem and the other extraction site. 3 millimeters, fair enough. since you're having two edentulous sites on both sides, but definitely you need some amount of expansion. We need an expansion here. Compared to the other site which you said, you can expand this site. Because it's not an interdental bone as such, it was the site of 6 previously. So you got 3. Because 3, within that 3, you can have a whole 3 millimeter of an implant here. Because both sides are edentulous. You are going to graft those two areas. So you'll get bone on both the sides. Since it's two edentulous sides, you can expect to get bone on both the sides. So you don't need much of a precaution in placing the entire 3 millimeter of preparation. But your implant starts from 3.3. Right? So some amount of expansion is needed here. So don't go in for a full preparation of 3. Stop somewhere at 2.8, then expand it. So mesially and distally are going to expand it. Let's see the other condition inside the bone, available bone height. So you have got 7 only here. This is very less. First thing is it's a molar site. You need maximum diameter of implant. You're not getting much diameter. That is the maximum what you can aspire is only 3.3. Not beyond it. Widthwise, 3 point, again, widthwise it's 4.1. Widthwise also 3.3 is the maximum you can expect. So beyond 2.8, you're going to expand it. Here also the same story. Lengthwise and widthwise, maximum drilling allowed is 2.8. Beyond which is expansion. Otherwise, you don't have enough of bone on the labial, lingual, mesial, and distal. So 2.8 is the only drill possible here. Rest is all expansion. So to place a 3.3, you can expand it to what level? Your drill, you've got only 3. Yeah. And what about the length now? What's that? It's only 6.5. It's not seen here. Same picture is not seen. Yes. What you see there is 7 millimeter. So you'll have to either go in for a shorter diameter implant, shorter implant, or you'll have to yeah, you'll have to raise the sinus flow, gain more length for the implant. What about shorter implants? You've got shorter implant of 6.5 length, but it starts with a diameter of 4.25 only. Otherwise, it will be like a pin. So if you can expand it to 4.25, you can think in terms of 4.25 into 6.5 and finish it off. Or else you'll have to go in for a sinus floor elevation, which will be 3.3 into minimum length is 8. So you'll have to expand it another 1 millimeter. If you can raise the floor, not expand, raise the floor to 1 millimeter additional, then you can think of placing 8 mm here. So you got two choices. Either expand it to 4.25. So that means you need to another 1 millimeter on both sides on the buccal and the lingual side. That means you'll have to stop preparing at 2.8. Then you will be using your expanders to expand it till you have to accommodate 4.25 diameter implant here. So it should be expanded up to at least, what is your size? Yeah. Yes. There you have expanders of 3.8, then 4.3. So you have to expand it to 3 and then 3.8, and then going for 4.25 implant of 6.5 length. Or if it is that not possible, if you cannot expand it to that level, then the second choice is to raise the sinus floor indirectly up to 1 millimeter and place 8 millimeter of implant of what diameter? Definitely, if you had gone up to 4.25, you would have placed it. So that means it's lesser than that. So it will be somewhere around 3.75. 3.75 into 8 with lifting the sinus indirectly, or 4.25 into 6 point. Clear? So both are under consideration. Let's see how the bone condition is. If it was all guided implant surgery, then you would have planned the entire thing and gone and did it in a few minutes time. Since this has got some amount of some skill, some technical know-how, a good amount of precision, everything required in between, it's all needed for a beginner. Guided implant surgery, and you can do it later as well. Unless you're well versed with the technique, all these things will become, you'll become a slave of the technology. So let's start off doing this. Any doubts? With which one? Sinus floor elevation. You try to augment whichever area possible here with your bone graft. Because this augmentation will help in some amount of bone on the labial side, right? Because you're placing all these implants on the palatal side. So labial side, if you get an augmentation, it's well and good. So place bone graft for all these cases. Because beyond lesser than 2 millimeter of jumping space, you don't need to place a bone graft. But you can definitely think in terms of augmenting that area to another 0.5 millimeter on the labial side. So place bone graft in whichever area possible here. That's all after placing the implant, right? So after placing the implant, have a proper view of that site. If that area demands bone graft, graft it. But you don't have any excuse of not grafting that 1.7 root stem area and 1.4-1.5 extraction site. That has to be grafted anyway, because it's going to be a mesial and distal site for one implant and another mesial and distal for the nearby other implant also. So grafting those two edentulous site is must. Extraction site. Rest we'll see accordingly. Okay? Yeah, let's have a review after the lesson is done.